Thank you. So what do we study when we try to improve safety? We study situations where by definition we say there was a lack of safety. I think we should study situations where there is safety. I mean, I know of no other science that tries to study its subject by looking at situations when the subject is not there. People have, for natural reasons, focused on the adverse outcomes and tried to look into them, and this has taken so much time and so much effort that they have forgotten to look at things that work as well. And that's what we're trying to say, that you can actually learn more from looking at things that work than from things that don't work. Afterwards you go out to lunch. I guess it's a buffet lunch of some kind. The question is, how often do you bump into other people when you do that? How often did you bump into other people when you had your coffee breaks? How often do you bump into other people when you go to King's Cross to take the tube or take the train? The answer is almost never. Why is the answer almost never? Well, the reason is that we adjust what we do to the situation without thinking much about it. Things go wrong because we adjust, and the adjustments are always approximate. They can never be precise. My message to doctors, as my message to everybody else, is think about what you're doing. Spend a little time to look at what you are doing and what others are doing, and try to understand how you actually accomplish it, because it's usually not the way you think about it. We have two terms that I didn't use here, but the terms are work as imagined and work as done. And what we find is that work as done is always different from work as imagined. So we need to learn from work as done so that the difference becomes less.
My one-page summary CV just has 2 words on it, very confused. And but what I have done is really gone around looking at a lot of different systems, trying to learn the lessons that can be learned between them and bring them back to medicine where we can.
There are always lessons to learn from other industries and good lessons that really inform your own practice and what you should be doing going forwards. But there's a caveat with that, and that is that you need to understand enough of both the industries to be able to move those lessons across.
This is the crew that I have the great pleasure of flying with at the minute. So this is Kent Surrey Sussex Air Ambulance. I started off with them trying to understand how this culture of this risk mitigation in both a joint aviation and medical culture could work, how it could be made to just operate safely, let alone operate safely and then make a difference. But as part of that investigation of how this system would work, I looked at what I thought superficially was a similar system, the MERT teams, the medical emergency response teams in Afghanistan, and superficially that looks like the same system. It's got a helicopter, it's got doctors, it's got paramedics. They have become pretty undeniably the most successful trauma system in the world. And they both work, but they don't share as much as you think. And there are fundamental differences between those two systems and their concept of operations. So there are things to learn, they're just not the things that I thought they were there to learn. Really, it isn't what I thought it was. It isn't a way of delivering a team to the point of injury. It's a way of delivering a part of the hospital into the battlefield during a live fight. Systems that look superficially similar, helicopter, doctors, paramedics, can be fundamentally different, and you have to be careful about the lessons you learn between the two. You must not make the error of false equivalence. Flight 1549 lands on the Hudson. My medical colleagues are saying, you know, what lessons can we learn? Why can't doctors be more like pilots? We're very quick, so the journal Chest publishes this paper that lays out in quite exquisite detail the architecture of that flight which landed on the Hudson. I'm sure we all remember it, 2009. But the important point here is not how cool they were. It's really that you can recreate this conversation to the nearest second over the entire period of that crisis. And in operating theatres, we can't do that. We don't do that. We don't have that fidelity in retrospect.
So the gold standard way of learning about what happens in the operating theatre is to actually record it. And that's what pilots started to do back in the late 1970s. And that's what we're starting to initiate at Sick Kids. Things are at the drawing board stage, but we're putting together protocols to have audio recordings. We're all taught how to operate and how to cut things and sew things, but we want to learn more about how the team interacts, particularly in crisis situations. That is mandatory in pilots, and it has been for 20 years.
The number of times you come away in a hospital from a sweaty moment and you sit down with the notes and then you write a thing that says in retrospect, and then a complete work of fiction afterwards, because you can't remember those events. You've got absolutely no chance of remembering them accurately with respect to time and indeed what happened. The aviation industry knows that it only learns lessons with good retrospective data. That's why you have a cockpit voice recorder, that's why you have a flight data recorder that tells you about those vehicles and that crew's behaviour up until the moment in which the thing became non-viable. That's why aviation has been able to build safety into their systems. We don't do enough of this in medicine.
We consider every patient's journey to be a flight. So when they start arriving in the operating room, they then move up in risk, and then we want to see increments downwards in risk thereafter until they're discharged. When they come in at the start of that flight, in inverted commas, we create a flight plan, which is all of those patient threats and problems and background and previous clinical history. We prescribe exactly what it is we're going to do. So we create literally a flight plan and we discuss it in front of the whole group. Our intention is to do what we said on the flight plan, and medicine is not like that. Unfortunately, the patient throws problems at you that you need to deal with, and we then track what the patient's flight is actually like, and we plot all the events that happen on this so that we get essentially a map of the patient's journey with the problems on it, and we can tell which of the problems were threats that came at us that we tried to deal with, which were errors that we made, where the clinical impact was on the patient, and we can try and learn from those interplay between the threats and the errors. Threats do trigger errors to occur every so often. They can still be recovered and mitigated, but if they're not, they will then lead to some unintended, undesired consequence. And that can still be controlled and recovered. But if it's not, we now know that these states tend to cycle and cause more error and more unintended state, which leads to progressive loss of safety margins and the perfect substrate for a major disaster. About a fifth of all of our patients sustain an error, which then leads to an undesired consequence, which then leads to chains of further error and further consequence, which we call the cycles of error, and they are very dangerous. Even small, tiny, random events can just suddenly blossom into something bigger and bigger unpredictably, and that's what makes life interesting. In high-stakes industries, we're trying to do the opposite. We're trying to contain all these little butterflies. If each one's a little threat or something, we're trying to deal with that. We can't get every butterfly, but what we should be looking for is a pattern where a few random things have clearly snowballed into a situation where we are outside where we anticipated being. We have deviated from our original plan. The way for dealing with them, we've learnt from the cockpit, is exactly the same as pilots are trained to do. You need to recognize that that's happening. It's not always as easy as it sounds. Then you need to trap it and mitigate it.
We're going to talk now about a changing culture in a hospital in Cincinnati. I'd very much like you to welcome to the stage our next speaker, who is Stephen Muthing, who's the Vice President for Safety at Cincinnati Children's Hospital.
I lead safety at Cincinnati Children's, but I also lead a network across the United States of the children's hospitals. And I just want to tell you a story about it. About 3 years ago, well, it starts before then. It really started about 5 years ago when the 8 hospitals in my state, the state of Ohio, our leaders agreed to work together on safety for the very first time. And we figured out some early wins. But really it started about 3 years ago when the children's hospitals across the United States agreed to come together and work on this together. We now are covering over half of the admissions to the children's hospitals already in the United States. And the amazing thing is none of this is mandated. It's all voluntary. And here's the interesting thing. It's our chief executives, our senior leaders, our CEOs who started this and are spreading it. So what's happened? You know, interestingly, when we started, we were lost. We didn't even know what to do because we didn't even know how much harm was happening. We had to agree on how are we going to define serious harm across the children's hospitals. We found that we were seriously harming 500 children per month. That's 16 a day. That's one every almost hour or two. It was devastating to us. So we had to start with the goal. What are we going to do about that 500 a month? We agreed this was our goal. 0. Not 10% reduction, not 20% reduction, 0. Because we didn't agree to 0 at your hospital and then 0 at this hospital. We agreed that we were going to get 0 across the nation. And so that the events that were happening at your hospital, I owned those just as much as you did, and vice versa. We do it for the kids, but analysts have come in and said, we've already, in just this time, driven out over $45 million from the healthcare system. We needed to figure this out, and somebody within those 80 hospitals surely has the answer. And so this reduction you're seeing right here in just those 3 years is not because we came up with some new idea. We just found what people were already doing and started sharing it. Our mantra is all teach, all learn, and nobody can stand on the sideline. Somebody is always better than you. Be humble and just go ask them what they're doing. And the flip side is you're always better than somebody. So be gracious and share what you're doing. It is no longer okay to compete on safety. We're all in this together, and I have to tell you personally, I'm to the point where I think it's immoral to not share. We have to act like lives depend on it, because the reality is lives depend on it.